Hello there. Today we are going to talk about the basics of shoulder radiographs and osseous anatomy. To evaluate the shoulder with radiographs, we usually obtain 2 to 6 views depending on the clinical history. So let's start with the basic osseous anatomy as it pertains to the radiographs. There are three main osseous components of the shoulder. The humerus, which articulates with the scapula, a mostly flat and complex bone that besides articulating with the humerus, it articulates with the clavicle and also with the thoracic cage. Important landmarks in the proximal humerus are the humeral head, the greater and lesser tuberosities, where the rotator cuff muscles insert. Other two important surgical landmarks are the anatomical neck, represented here with a blue line, and the surgical neck, represented by the red line. The clavicle articulates with the scapula through the acromioclavicular joint and held in place by the coracoclavicular ligaments. The scapula is composed of the coracoid, which is anterior, the acromion, which projects posterior, the glenoid, which articulates with the humerus through the glenohumeral joint, and the spine of the scapula, which divides the flat bone between superior and inferior portions. The most common view of the shoulder is the anteroposterior view, or the AP view. In external rotation, this is the anatomical radiographic view. Note that the greater and lesser tuberosities lie somewhat lateral as they are exposed when the arm is externally rotated. Also note that there is overlapping between the medial aspect of the humeral head and the glenoid. The reason for this is that in the AP view, the body and not the shoulder is in true anteroposterior positioning. Because of evolution and the development of hand-eye coordination, the scapula are slanted or angulated 45 degrees anteriorly, so in the AP view, the humeral head is lying in front of the glenoid and not adjacent to it. That's why we can actually move our hands and see where they're moving. To solve this problem, we created the glenoid anteroposterior view, also known as the Grashey view. In this view, we shoot the X-ray beam obliquely to the body so there is no interposition between the humeral head and the glenoid. This way, we can better evaluate the glenohumeral articulation as well as the glenoid and humeral head surface. Here in this illustration, we can see that the body needs to be oblique for us to see the glenohumeral joint without bone interposition, again because the 45 degrees angulation of the scapula. We also have the anteroposterior view of the shoulder in internal rotation. Similar to the AP in external rotation, there is overlapping of the humeral head and the glenoid. Note that in internal rotation, the greater and lesser tuberosities project medially, superimposed over the humeral head. This superimposition gives the proximal humerus in internal rotation the appearance of an ice cream cone. So now you know that if the proximal humerus looks like an ice cream cone, then it's an internal rotation view. Here for comparison, the different appearance of the proximal humerus in internal and external rotation. Another view we obtain, especially in trauma, is the axillary view. This view is obtained by having the arm in abduction and shooting the X-ray beam through the axilla. So in essence, we're looking at the glenohumeral joint from the floor up. It's important to note the anatomical landmarks here. Anteriorly, we have the coracoid process. Posteriorly, we have the acromion, overlying the humeral head, and preventing it from dislocating superiorly. And then next to the acromion, anteriorly, we have the clavicle. The most important aspect of the axillary view is to evaluate the relationship between the humeral head and the glenoid. The glenohumeral joint is extremely mobile, but it comes at the expense of being extremely unstable. That's the reason it dislocates frequently. In the axillary view, if the humeral head is no longer articulating with the glenoid and lies in the direction of the coracoid, we know it's an anterior glenohumeral dislocation. Conversely, if the humeral head moves away from the glenoid and lies adjacent in the direction of the acromion, we then know it's a posterior glenohumeral dislocation. The last shoulder view is the transscapular Y view. Here we shoot the X-ray beam through the humeral head, and we expect it to be right in the middle of the scapula. We usually get this view when the axillary view is hard to obtain. Again, the coracoid process is anteriorly, the acromion is posteriorly, serving as the roof of the humeral head. Lastly, we have the clavicle articulating with the acromion. In the transscapular Y view, it is important to assess the position of the humerus, noted with the red dashed line with respect to the glenoid. The glenoid should always be in the center of the humeral head. Similar to the axillary view, if it's displaced in the direction of the coracoid, then we are dealing with an anterior glenohumeral dislocation, And if it's displaced in the direction of the acromion, a posterior glenohumeral dislocation is present. Now you know. Thank you.